Okay, let's get started. So we're going to do GI radiology today. The content is based on the USMLE content list as before. Huge thanks to Amy who helped me with this lecture. There's a lot to cover today. So this is very interactive as our prior lectures. So this patient presents with dysphagia. What is the study? Upper GI, good. Well, it's an esophagram, good, but it's similar. And we'll talk about the differences. This patient presents with left lower quadrant pain. What is going on? Left lower quadrant pain, what is going on? So Jordan thinks diverticulitis. Okay, good. Anyone else? Where are my diverticulosis? Good. Ulcerative colitis? Good. Okay, let's keep going. Where is the abnormality? Young patient with abdominal pain. Which segment of the small bowel is abnormal? The jejunum, the ileum, the duodenum, or all of it? Not sure. Okay, that's reasonable. What study is this? So this is a CT scan, and you see I give you 3 different phases. We call the phases. The first phase is dark. The second phase, it's enhancing, but only certain things are enhancing. Whereas the third phase, some parts of it are... It's hypoenhancing on the venous phase. Correct. So it is with and without IV contrast. Good. So this one is without, because it's dark. And this one is with. And you know that because the aorta is bright, but the brightness of the aorta changes. What is this procedure called? So the patient has the same diagnosis as the previous one. Good. Angiography, good. And can you be specific about what kind of angiography? Angiography is diagnostic, meaning we're just trying to figure out what's going on. Therapeutic means you're actually trying to treat the underlying tumor, which we see in this case. What is the diagnosis here? Patient comes in with abdominal pain, nausea and vomiting. This is a CT scan, and you see that some of the bowel is really dilated, and some of the bowel is completely decompressed. IBD, yeah, possibly. Ulcerative colitis, that's a good guess. Toxic megacolon, okay? So all the guesses so far have been regarding colon. So colon is a picture frame, so it's ascending is right here, transverse is right here, and then the descending is right here where the gas bubble is. So this is more central. So in the center of the abdomen lives the small bowel. So this is more of a small bowel process. So we'll talk about that. What is this study? And why do we use this study? It was approved by the U.S. Preventive Task Force in 2016 for screening for what though? And don't know. Okay, we'll go over that. What is this study? So this study has the best soft tissue resolution. And I'm showing you a specific sequence on the study to discuss a topic. Good, it's an MRI, good. There's several diseases on the USMLE content list that uses these 2 sequences to diagnose the patient's condition. So normal structures, this is sort of your basic first year material. It's just from your mouth to your anus. That's the GI tract. So here is a CT abdomen and pelvis. And is this normal? What do you think? Colon looks abnormal. Good. Okay, so when we describe abnormality, we think about thickness and dilatation, caliber. Is it thick-walled or is it distended? You can also evaluate thick-walled. Good. So this is the transverse colon. So there's 3 mesocolons. There's a transverse mesocolon, which is what this is. There's a small bowel mesocolon, and then the third mesocolon is a sigmoid, but we can't see in this image. But the mesocolon, what do you think about these little linear vessels? What is that? So this is an engorged vasa rector. Those are the little vessels that feed the mesentery, and so it's thick-walled. And you can see here there's this is free fluid. So there's inflammatory changes and there's free fluid. Good. So this is pancolitis. Pancolitis means the entire colon is inflamed. Depending on the patient's clinical context, it could be from different causes. So if the patient comes in with prior antibiotic, broad spectrum antibiotic for treatment, and they wipe off they wiped out their colonic flora, then they're going to get this condition called pseudomembranous colitis caused by C. diff. This is treated with vancomycin or Flagyl, or in very severe refractory cases, fecal transplant. So a stool from a normal patient is then put into the stool of the sick patient to reconstitute the normal flora. What segment of the bowel looks abnormal? So this one, a small bowel is abnormal. So here, this is normal bowel. Jejunum is here. Jejunum is the proximal bowel. The ileum lives here. That's the second half of the bowel. They're in different locations. The duodenum rotates. I don't know if you can see it here, but the duodenum sort of, it's a C loop. It goes from the right, crosses the spine, under the SMA, and it goes to the left. And this is where the jejunum is. And this is ligament of Treitz is right here, and the duodenal-jejunal junction. So here, the normal bowel wall should be less than 3 millimeters. And if you look at here, it's thick. The normal caliber should be 3 centimeters. So it's the rule of threes. And so the caliber looks fine, but the wall looks thick. And if you look here, there's also an abnormal segment here, abnormal segment here, here. So it's a pretty diffuse, like ileal wall thickening. So this is what we see with inflamed bowel, and that condition is called enteritis. And enteritis can be from different causes. It's infection, ischemia, so the patient, but then also radiation. People who've had prior radiation therapy will get radiation enteritis, and shock bowel, so just from hypoperfusion. Okay, so this one is, what kind of image is this? Good, ultrasound, and this one is CT in the right upper quadrant. These two images are what? MRI is, you can think of it like your phone. On top of it, you have apps, so you can have a lot of different apps. So MRI, you have the magnet, but within the magnet, you can put different recipes of sequences, which are like apps, and each sequence tells you slightly different information and serves a different function. One of the app is called, or one of the sequences is called diffusion weighted imaging, DWI. And what that looks at is water motion. So if you have like a sponge, right, and you put the sponge in the water, the sponge will fill up with water, obviously, right? Let's say within that sponge, you put a gummy bear in the sponge. It's going to soak up the water less, and it's restricting the water less. And that's what an abscess is. An abscess is a really thick collection, like a gummy bear. It's incredibly thick, right? So water can't move around as much. So it restricts water motion. And that's what we're seeing here, is the water motion in this abscess is being restricted. So it's really bright. It's the gummy bear within the liver. So that's what the DWI is. It's helpful to show you restricted water motion. So it can be helpful in the setting of abscesses, tumors. It has a thick wall here, if you can see. And the wall, the phase is a little off, but it's enhancing. And there's a lot of, it's not a simple fluid like water. It's complex, thick, viscous abscess, okay? So typically abscesses, we say the rule of thumb is 3 centimeters. If it's greater than 3 centimeters, it needs to be drained percutaneously. So the interventional radiologist just puts a wire and a pigtail catheter in here. If it's less than 3 centimeters, then you can try a trial of antibiotics, and then see if that will work. Good. So what study is this? This was just FDA approved last year. Good. Yeah, this is contrast enhanced ultrasound. Does the same thing as other contrast enhanced studies do, but it's CO2. It can be done with patients with renal failure because you just breathe it out, right? CO2 is part of our buffer system. Septations and thickening, and then there's an area that's non-enhancing corresponding to there's large volume. But what do you notice about the peritoneum? So we have the visceral and the parietal peritoneum. It's thickened. Yeah, it's thickened, and you can see it. It's enhancing, and it's inflamed. Exactly. So there's something that's causing the peritoneum to become inflamed. And so this one is peritonitis. So here is a patient who comes in. The abnormality is this. an enlarged lymph node. Lymph nodes shouldn't typically be really tiny, and they're kind of bean-shaped. Once they start to get enlarged or look like a ball instead of a bean, then you start to worry about some kind of disease process. So Whipple's disease is caused by an infection, actinobacteria. Patients typically present with lymphadenopathy, and the lymphadenopathy is pretty remarkable, and it's low density. So it's not density we think about relative to water, low density compared to, say, soft tissue, which is isodense. So this is Whipple's disease. This is one of our quiz questions. So this is a CT enterography. So enterography, it is a CT of intestines, and we do a special study. The water, the fluid is low density, so we call this negative contrast because it's dark. In contrast to positive contrast, which is bright. Negative contrast allows us to see the lining, the wall of the bowel better than positive contrast. So here what we see is, this is normal bowel up here. Wall is thick, reaction. So they call this the comb sign because there's engorged vasa recta. And what do you think about the enhancement of the bowel wall? Hyperemic, good. So there's bowel wall thickening, hyperemic bowel, so it's acutely inflamed, and there's engorged vasa recta, and we only see one segment. But this is Crohn's, or this is one presentation of Crohn's. Crohn's, there's several. There's active inflammatory, which is what this is, because it's acutely inflamed. You told me that there's a hyperemic and this thick wall. So here is an MRI enterography. So this is a CT. You could do the same thing with MRI. MRI is better. Keep your eye focused on this point. You'll see that several of the bowel loops are getting tethered. And this is we call this penetrating disease, where there's inflammation and it causes the bowel to become, to one point. And eventually it can develop strictures right there, a segment of bowel that's really narrow. So that's stricture. When after a while the inflammation can settle down, and then it can scar down and become stenotic stricture and then cause bowel obstruction. And you treat it with biologic agents, steroids, and in some cases you have to do surgery. Ulcerative colitis is the other form of inflammatory bowel disease, and mesentery, it's like engorged. And it's a continuous segment, right? So here, that's the descending. There's the rectum, and you see the sigmoid, and then it extends into the rectum. So it's a continuous long segment thickening with sort of a little bit of hyperemia. So this is called lead pipe colon. We see this with ulcerative colitis. They lose normal haustral folds. So here's the normal haustral folds. And you lose that. You lose all that. So you lose the normal morphology. The wall becomes sort of straight and narrow, and that's what ulcerative colitis is. And in severe cases, the only way to really correct it long-term is to do a total proctocolectomy. So here, what do you see on this radiograph? This is normal-looking radiograph. The colon is huge, and there are a lot of causes of toxic megacolon, including pseudomembranous colitis, Crohn's, etc. It's critical to treat the underlying cause to prevent perforation. Moving on to the next section, and the next topic is neoplasm. This is CT pelvis, and we see this mass in the rectum. So this one was found incidentally, but this was the corresponding MRI rectum protocol that was done to look at the mass, because they wanted to know the spread, the T staging, we call it. So MRI helps determine if it's a T2 versus T3 disease, because T2 is treated with surgery, whereas T3 is treated with chemoradiation. The American Cancer Society currently recommends screening colonoscopy or CT colonography in patients who are 45 years or older. These are the new guidelines as of last year. Age was changed from 50 to 45. There are several risk factors. Patients who have adenomatous or serrated polyps, familial cancer syndromes like FAP, Lynch syndrome. Also, IBD increases your risk. So patients with the ulcerative colitis are at increased risk for colorectal cancer. Smoking, eating processed meat, and low fiber diet. So this is what a CT colonoscopy look like. So you know about colonoscopy probably. You could do the same thing virtually with CT scanner. So you insufflate the colon with CO2, about 6-7 liters, right? That distends the colon, and then you get a CT scan. And then the computer generates a virtual colonography like this. So you then can look for polyps and masses and lesions as part of screening. But in addition, you also get the rest of the abdomen too, because you can, you get everything else as well. So this is approved by the U.S. Preventive Task Force as screening for colon cancer in addition to colonoscopy. So this is a double contrast, you see, because the patient has bubbly air, like it's like Alka-Seltzer, and then there's contrast as well. So it's a double contrast. So you see air and contrast. So this is normal. This is a normal esophagram. This is, what do you think about this? Is this normal looking? What's abnormal about it? What do you think? Let the patient go, nothing to do, don't worry about it. Slow movement of fluid. Good. Yeah, it's slow. And what else do you notice about the wall? There's these webs, right? There's like filling defects. We call them filling defects. It's irregular. This is a CT scan of the same patient. And so you can see this is esophagus, or this is the area that we're imaging, and there's esophageal cancer. And these are the mass. And it looks webby because you have all the small, sort of just ulcerating and invading. So that's why it looks webby and whatnot. So worldwide, squamous cell is the most common, but in the United States, adeno is actually the most common. And it involves the lower third. Squamous cell involves the upper two-third. And adeno is what's seen with Barrett's esophagus, metaplasia, and then they are at an increased risk for developing adenocarcinoma. So here, this is another esophagram, and what do you notice about distended esophagus? So this is a web. Very good question. So there's a waist here, like someone's pinching that collar there. So that's a web, and it can cause dysphagia. So this one is from Barrett's esophagus. So Barrett's esophagus is when you have transformation of normal esophageal epithelium into abnormal epithelium. And typically, so here's a G junction. This is the distal esophagus. And so you see this stricture is sort of in the mid-distal esophagus, right? It's not in the distal esophagus. It's in the mid-distal. And the reason is because this particular area, that's the metaplastic portion. So the normal portion is here. The transition is here. So when the patient has reflux, the transition point is where it gets strictured down and narrowed because of the acid irritation. And that's why the stricture is in the mid-distal, in contrast to normal reflux strictures, which are typically down here. Reflux strictures, the normal transition is down here, so then that's where the stricture happens. But in Barrett's, it's up higher in the mid to distal, where the transition from metaplasia to normal epithelium is. Good. So we're gonna still in malignancy. Okay, so this is a CT abdomen and pelvis, and I'm showing you this because I want you to look at the stomach. The stomach here, this is a normal stomach, but here, if you look at the stomach here, it's incredibly thick, right? And there's little polypoid lesions as well, like diffuse sort of thickening of the cardia and the fundus. Around the pancreas, there are lesions. This is a patient who has an MEN syndrome. So patients with MEN syndromes get like pancreatic lesions, they get parathyroid lesions, pituitary lesions. So this patient has these little, this is called a dotatate study. It looks at somatostatin expression, which we see with neuroendocrine tumors, and MEN is one of them. So here we have uptake of dotatate in the peripancreatic masses, and there's sort of scattered uptake within the stomach. So this is an MEN syndrome consistent with neuroendocrine. And so this is, we call it the Zelinger-Ellison syndrome. So the gastric wall becomes thickened because the gastrinoma releases gastrin, which causes hyperstimulation. So you see that. So this is ZE syndrome, and it's secondary to gastrinoma, which we can see better on the dotatate study because right there, it's taking it up because it expresses somatostatin. Okay. So in ZE syndrome, we get thickened rugal folds, which we see here, multiple gastric. There are different types of neuroendocrine tumors. The traditional classification had been based on the naming, carcinoid, lipomas, gastrinomas. The new WHO classification is based on grades, grade 1, 2, 3, based on Ki67 expression. Cancers, still in cancer. Here we have an upper GI. So upper GI is an esophagram plus the stomach. So let me just orient you. This is the lesser curvature. This is the greater curvature of the stomach. This is the contrast in the fundus. And then this is the contrast in the rest of the, like the body, and the antrum of the stomach is here. So we have these little round filling defects, right? So it's pooching in, and so then the contrast goes around it. You know, a nodule within the stomach. And the nodule could be anything. It could be hypoplastic nodules. It could be adenomatous nodules. It could, I mean, in this case, this was a, you know, carcinoid, but you can't get the histotype based on the imaging appearance, although we can give a differential diagnosis. But this patient also has this finding, which is a lymph node metastases. And this is a special kind of lymph node metastases because it has these radiating structures here that's pulling the bowel in, or desmoid reaction. And this is classically what happens in patients with carcinoid. Carcinoid is a small bowel tumor, and the bowel, the carcinoid will metastasize to the lymph node and then cause this reaction that pulls the different bowel segments into it, causing a desmoplastic reaction. So this is small bowel carcinoid. It's a type of neuroendocrine tumor. They release serotonin, and that can go into the portal hepatic system and cause the serotonin syndrome, or carcinoid syndrome, which is like they get diarrhea, flushings. So we can see that this is a nice study. It's, you know, well distended stomach, and we see this little thing hanging off the wall, stomach wall. So it's a soft tissue mass, and it's off the wall. And so this is typically how gastrointestinal tumors look like, the GIST. So GIST is a tumor that arises from the submucosa, and it typically has this mutation c-KIT, which is important because you can target that mutation with Gleevec, which blocks this tyrosine kinase. And you know, so it shrinks it down, and then it can then be resected depending on how big it is. So this is GIST, typical presentation. In contrast to GIST, here is an MRI. So we see this contrast enhanced. So the mesenteric vessels, the SMA, SMV, they're bright. So it's the liver. And you can see the MRI, we can look at the bowel really beautifully, right? And this is the normal jejunum, and this is the normal ileum. You see they have different appearance as well, because the jejunum is, there's a lot more folds in the jejunum than there's in the ileum. And then the wall looks very thin, which is normal, and it's not distended, which is normal. But if you look at this segment of the jejunum, there is this bright structure here that's inside the wall, in the bowel, and it's enhancing. So this is a small bowel tumor. And small bowel tumors, there's benign and malignant. There's lipomas, which are fat lesions. And then there's malignant ones like carcinoid. And then you also have metastatic small bowel lesions, which are actually more common than primary bowel tumors. So here, in contrast, here's a CT abdomen and pelvis, coronal. And if you look at the stomach, so the normal stomach, we see the rugal folds. Here, we lose the normal rugal folds, and it's very thick. So this is an infiltrative process. So when we see this, we think about, this is called linitis plastica. It's gastric cancer, infiltrative gastric cancer, that causes there's no distension of the stomach because it's like tumor down. It's just, and then in some cases, it's gastric adenocarcinoma. It can cause obstruction as well. But you need biopsy because lymphoma can look very similar. The difference between lymphoma and gastric cancer is, lymphoma is a very soft tumor, so it doesn't cause obstruction, whereas gastric cancer is very hard, and so it causes gastric outlet obstruction. So this is what linitis plastica looks like from gastric adenocarcinoma. So here we have a thick-walled colon, and so we think in the caliber, right? So the wall should be less than 3 millimeters. This is the normal appearance of the wall. And here it's not, it's markedly thickened. And it's, if you look at the fat around it, you see that there's a little bit of abnormal increased signal density here. So this is infiltrative colon cancer. So it's sort of starting to invade the adventitia of the colon. So this is a Siegel mass, Siegel cancer. So that's colon cancer. Here's another segment of the colon, the rectum. So here's a mass. It's an MRI. And so MRI is really important for rectal cancer staging. So we see that this is the rectum, the wall of the rectum. This is the mesorectal fascia, this dark band. It's the fascia that surrounds the rectum. The normal wall is dark, and here it's gray. So we call this evil gray because now you're worried that the mass has extended beyond the wall and now into the mesorectal fat. That's the mass. And then here's the sagittal image of the mass. So malignant, we're going to move on to hereditary syndromes. So one of this is the hereditary non-polyposis, the Lynch syndrome, which is due to a mutation in the DNA mismatch repair. So patients get a lot of different kinds of cancer. Here's a patient who had primary rectal cancer. You see this is a normal bowel wall of the rectum. And then here you have bowel wall thickening and mass like soft tissue signal. And there's adenopathy here, lymph node metastasis. And then shortly like a year or 2 years after this mass rectal cancer was resected, the patient developed another tumor. Here you see this soft tissue mass in the retroperitoneum. It's encasing the vessels. So this is a desmoid tumor. Here you can see that this patient had the surgery and then had an ileostomy. So the small bowel was brought up as part of the surgery for the rectal cancer. And then we have here a desmoid. So this patient has Lynch syndrome. And in women, they can also get ovarian cancers. They can get uterine cancers as well. Here, what we see is these little soft tissue nodules here. That is, filling defects. So these are polyps. There's like tons of polyps. Little polyps here, polyps here. There's polyps everywhere. And this is FAP, familial adenomatous polyposis syndrome, due to APC mutation. And patients have a high risk of colon cancer, so sometimes they will get prophylactic colon cancer. The polyps here are in the small bowel, not in the colon, but they also have a high. Wait, I'm sorry. I think I made a mistake. This is colon. So we only see one slice of it, but yeah, there's a very high risk of colon cancer transformation. So many patients will just get a prophylactic total colectomy. Here is a CT abdomen and pelvis. It's calcified, yeah. So you see these calcifications along the wall. So this is called porcelain gallbladder. And patients with porcelain gallbladder are at increased risk for gallbladder cancer. Good, yeah. And if you look, you can also see that the background liver is not normal either. The liver is nodular. The liver is nodular, is shrunken, so the patient has background cirrhosis as well, which increases the risk of HCC in this patient. So the gallbladder was resected and there was gallbladder cancer within it. In contrast, this is a patient who came in with high bilirubin and jaundice. So they got a CT, abdomen and pelvis, and you see that this is the bile ducts. And right there, this is a CBD, and you have the intrahepatic ducts is very dilated. Normally you shouldn't see the ducts, and now we see it very well. And if you look down here, it tapers down into this area where there's a mass here. Yeah, that's cholangiocarcinoma. And you see the portal vein is right here. This is the portal vein. There's is very close to the portal vein. This patient, so this is Claskin tumor. There's different types of cholangiocarcinomas. The cholangio cancers that involve the hilum is called Claskin, but they can also be intrahepatic, peripheral, intraductal. But Claskin, this is a Claskin tumor. All right, so keeping in the same region, this is a mass that's in the liver rather than in the CBD that we saw the slide before. So this says non-contrast, everything's dark, the aorta is dark. This is contrast enhanced. There's arterial enhancement and venous enhancement. And you see that on the arterial, there's this enhancing, it's enhancing, right? This part is abnormal and it looks different from the rest of the liver. The liver looks abnormal too. It's very nodular, it's small, so the patient has cirrhosis. So there's this enhancing region, and on the delayed, so contrast, goes into the arteries, and then goes through the capillaries, and then through the veins, and then goes back to the heart. So this here, we're in the arterial phase, and this is in the venous phase. And we know that's in the venous phase because the hepatic veins, you can see the hepatic veins now, right? Sort of returning to the heart. So on the venous phase, the contrast washes out. It washes in, washes out. And so this is, we call HCC, hepatocellular carcinoma, and this is diagnostic, wash in and wash out appearance in patients with cirrhosis. And we use this category called LIRADS. So tumors have increased neovascularity. They just have a lot more blood vessels going in, so that's why it's enhancing. And there's a lot more blood vessels that drain the sort of angiogenesis, right? So it drains the blood supply, so it washes out. The blood drains faster than the normal background parenchyma. So this is diagnostic for HCC because the patient has background cirrhosis. And the way to treat HCC is to, depending on the size, the definitive treatment is liver transplant, but organ allocation is limited because we don't have sufficient organs to meet everyone who needs it. So there's TACE, transarterial chemoembolization. So HCC, we said, is very vascular. So there's a lot of neoantigens. So you can see this parasitic vessel here that is supplying this mass. So you can block that artery with little beads, and that's what we see here. You block the supply and kill the tumor. So this is called transarterial chemoembolization, TACE. Patients, and that's reserved for like larger tumors. Patients who have smaller tumors, like we see here, there's this little focus here. It's smaller, as you can see, compared to the other tumor that we saw. They can get an ablation. So an ablation, you see this needle here, it's going in, and and at the tip, it burns. So you basically burn the tumor. And it's done percutaneously through the skin, and patients come in for the treatment, and then they leave the same day. And then this is the post-ablation treatment. So you can see this is the area that got burned by the tips of the ablation probes. So now it's no longer enhancing like it was before the ablation. Okay, so this is called ablation. And so those are the different ways to keep the tumor under control until the patients can get liver transplant. All right, keep moving on. So malignant neoplasm. So this is peritoneal. So this is a CT abdomen and pelvis. There's oral contrast. If you look at the bowel, there's contrast. And then there's large volume free fluid. So, but it's not a simple fluid. Look at this. So you have these little nodules here on the side. If you look at the mesentery, it's sort of messy, kind of dirty looking. And there's nodules everywhere. So this is called peritoneal carcinomatosis, right there along the diaphragm. You can see the carcinomatosis. This is called carcinomatosis when you have cancer that's spread into the peritoneum and mesentery. So it's common places are mucinous tumors, so gastric cancer, ovarian epithelial neoplasms, mucinous adenocarcinomas, serous adenocarcinomas, pancreatic cancers. So it all means it's distant spread. When you have gastric cancer with peritoneal deposits into the ovaries, that's called a Krukenberg tumor, when you have gastric cancer implants that go down into the ovaries. So it's just peritoneal spread of cancer. This is an MRI. And here we have the liver, and this is a stomach. And then this is the CBD right here. And then this is the gallbladder. The pancreas is in this region down here. So here, if you look at the CBD, it's very dilated, intra and extrahepatic. And then if you look, there's a sharp tapering, not narrowing right here. A sudden narrowing. And then if you look carefully, there's this mass here. It's a pancreatic head mass. So that's what pancreatic cancer looks like. Here is the MIP version of this patient. So there's a sharp cutoff here, and the patient has severe biliary dilatation from the pancreatic head mass. So they have this thing called a double duct sign. That's when you see both the CBD as well as the portal vein. But that's on ultrasound. I mean, we don't really. And then sometimes it can obstruct the pancreatic duct as well. So actually I'm sorry, I made a mistake. Double duct sign is when you have the pancreatic ductal dilatation with the CBD dilatation. We don't have the pancreatic ductal dilatation here, but we have the CBD dilatation because it's invading the proximal, the distal CBD. So that is pancreatic cancer. So achalasia, okay, now we're moving on to the esophagus. 920. Okay, so here is an esophagram. And what you see is there's abnormal, so there's primary and secondary contractions, but it's abnormal because it's the GE junction, it doesn't open, right? So normal fluid, when they drink it, should go through the GE junction, and it's not. It stops at the GE junction. And this is a cynate, but there's this beak-like appearance because it's just not able to go, and there's this trickle of contrast that goes down. Here's another patient with the same condition. They drink the barium, and there's a little trickle here at the GE junction, and it just stops here. So this is called achalasia. Achalasia is when the myenteric plexus are not working well, so the lower esophageal sphincter does not relax. So the only way for the fluid to pass is when the pressure in the esophagus exceeds the pressure of the GE junction, the lower esophageal sphincter. There's primary and secondary achalasia. Primary is from, we don't know what it's from, but secondary is from Chagas. There's a lot of different causes. But the way you treat it is to a myotomy. So you cut the muscle to relax it. And that can be done endoscopically or surgically. Okay, this is in contrast to what we just saw. Here we have tertiary contractions, right? Look at this. It's abnormal. And this is called dysmotility. Dysmotility just means there's no obstruction like we saw with the achalasia, but the actual contractions are abnormal and non-propulsive. So that can cause patients dysphagia. In contrast, here is a web. So the patient drinks, and you see this little waist here is pinched. So that's a cervical web, and that can obstruct. So if the patient, took a big solid bolus of food, it can get stuck here. So this is called a Zenker's diverticulum. The outpouching is seen posteriorly, and so the esophagus is here, and then this is the outpouching, and patients can have food that gets stuck there, and they can have severe halitosis, and it can be resected. More problems with esophagus. Here, this is a CT scan. This is the pulmonary artery. This is posteriorly, and the posterior mediastinum is the esophagus. And so this is the esophagus, and here we see air outside the esophagus. The esophagus is thickened, and there's air, so there's esophageal perforation. One of the syndrome that's been described is called the Mallory-Weiss syndrome, and it can cause in the subcutaneous tissue because it's continuous if it's severe enough. Perfect. So here we have a CT abdomen and pelvis, and this is the stomach that's gone up into the chest cavity, and that's called a hiatal hernia that there's different degrees of it. Like the whole stomach can be inside the chest wall. So this is a esophagram. This is the heart in the background. This here is the diaphragm. So you see that the stomach is part of the stomach, or majority of the stomach is in the chest. So this is called a hiatal hernia. And sometimes it can cause dysphagia, and patients have to get that surgically corrected. Here's another example of a nice stricture, a web, so esophagram. And so you see the distal esophagus, there's this waste that can cause dysphagia. So this commonly is from reflux stricture in the distal esophagus. And we said before, if it was like Barrett's, it could be here or even more proximal at the transition point between the metaplastic and normal epithelium. Here, you see that there's abnormal distension, right? So this is a normal distension of the esophagus, but here it's just a straight, narrow pipe tube. And this is stricture. It's a long segment stricture of the esophagus that can happen from radiation. Patients who've had prior NG tube placement for a long time can stricture down, or people who try to commit suicide and drink lye can stricture down the entire esophagus. Okay, we're moving on now to digestive systems. So here we have a patient with right lower quadrant pain, and this is the appendix right there. So this little blind ending tube, there's fluid, and there's little dots in it. That's called appendiculate, little stones. And if you look at the fat around the appendix, it's gray, right? We call that stranding because there's fluid that distends, that sort of intercalates into the fat. So this is appendicitis. Appendicitis is treated with surgery, except if it's perforated. This one is not perforated, but if it's perforated, it can cause an abscess, which then needs to be drained by interventional radiology since it's already perforated. Here is a MIP image, and what we see here, this is abdomen pelvis. Here's a kidney, the liver, spleen. Here's the portal vein, splenic vein, and SFV. And there's abnormal tortuous little vessels here. Abnormal tortuous vessels. This is called angiodysplasia, where you just have this abnormal malformation of like AV malformation. And that's important because it can bleed sometimes and cause GI bleeding. So if we find that, then interventional radiologists, they go in and they embolize this. Just like we saw the embolization of the liver mass, they can do the same thing, but target it to the abnormal tangles of vessels. Here is a patient with left lower quadrant pain. Moving down the list. So here we have a CT abdomen and pelvis coronal with oral contrast and IV. The portal vein is lit up. And we see this patient has diverticulosis. But in addition, there's bowel wall thickening, and the paracolic fascia, this thing here, is thickened, and there's mesenteric stranding. There's this fat stranding because there's fluid. So this is a complication of diverticulitis. Of diverticulosis. It's diverticulitis, and it's simple. There's no abscess, but sometimes it can perforate, and then patients get abscesses, which have to be drained, and sometimes they can fistulate into the bladder, into other parts, vagina. So it can become very complicated. Patients have to get an evaluation, colonoscopy later, because it can mask colon cancer as well. Here is a very zoomed in view of the duodenum. We're moving on to the duodenal. So this is the liver here. This is very zoomed in. This is pancreas. This is the duodenum. And you see the duodenum, there's thickening, and there's also stranding in the fat. So this is duodenitis. And the duodenitis is it's just inflammation, but it can be from ulcers. It can be from trauma. It could be, various post-ERCP, where they accidentally perf the duodenum. So this is what duodenitis looks like. And you want to look for free air to make sure there's no perforation, because that has to be surgically corrected if there's perforation. Okay, peptic ulcers. Okay, so here is a CT coronal image. This is the stomach, liver, large bowel, heart. And this is the greater curvature of the stomach. This is the lesser curvature of the stomach. And we see this abnormal outpouching here. So this is called an ulcer. An ulcer is it's a cavitation within the wall. And this patient had an upper GI as well. We said before, upper GI is esophagram plus evaluation of the stomach. And you see this outpouching that corresponds to that ulcer. So this is a giant ulcer, most commonly from H. pylori. Now with antibiotics and protonics, we don't really see it as much anymore, but this is what ulcers look like. Okay, so granulomatous enterocolitis. This is another name for Crohn's disease. We talked about Crohn's earlier in the inflammatory section, but we're going to review it briefly in the digestive section. So Crohn's, it involves from your mouth to your anus. It has skip lesions, so it can involve the bowel and also segments of the large and small bowel. We said there's different types. There's inflammatory, active inflammatory, and you can also have fibrostenosing stricture. So here you see the lumen is narrowed, the bowel proximal is dilated, so there's an obstructive stricture. There's submucosal hyperemia, so there's an active inflammatory component on top of the stricturing process. And if you look at this, there's this radiating part here, right? It's the central radiation here, and that's fibrostenosis, fistulous. So it's called penetrating disease. It's just inflammatory, so it brings all the loops here. So that's classically seen with Crohn's, not ulcerative colitis, which typically only affects the colon and does not have the penetrating process or involves like other lesions, other segments of the small bowel. So that's Crohn's. It also has non-caseating granuloma on histology. Here's Hirschsprung. Hirschsprung disease is the aganglion. So it's the normal nerves are not there. So the patients get megacolon because the rectal, the segment that's affected just doesn't open up because there's absent normal nerve supply, ganglion. So this is a barium enema. So they put contrast through the rectum and into the colon, and you see like the rectum is very small relative to the sigmoid colon. So that's how you diagnose Hirschsprung. And babies, we see this with young children, and they have to get surgically corrected because they have problems defecating. Okay, so let's move on to common things. So now we're talking about adhesions and small bowel obstruction. So patients who have surgery, they can get scarring, bands, that's called adhesions. And the adhesions can come anytime after they've had prior surgery, and it can cause obstruction. Here we have small bowel that's very, very dilated. The distal bowel is decompressed. It's like if you had a water hose and you kinked it on one side, the upstream water is going to get really big and the downstream water pipe is going to get really small because you have a kink. And that's what we have here. You have a kink, and that arrow points to where the kink is. And so that kink is most commonly from adhesions, just because of the prevalence of surgery. That's the most common cause of obstruction. But other things that cause obstruction are hernias and cancers. So you got to look for those two. Intussusception. So here, intussusception is when you have telescoping of bowel into bowel. So here, right there, we have a bowel, and it's going into the bowel, and there's this dark piece in there, this little dark, fat, attenuating piece. That's a lipoma. So that's acting as a lead point for the intussusception. So intussusception can be seen incidentally in children, like if they have viral infection, but in adults it's abnormal, and you have to look for a bowel lesion. Here we see a lipoma that has been the lead point for the intussusception. This one is another coronal CT abdomen pelvis, and here what we see is abnormal air in the mesenteric vessels and in the liver. You should not see air in the liver or in the mesentery. So, and it's a special kind of air because you could see it's like tracking along the vessel. So it's not free air. It's not like pneumoperitoneum. It's air within the venous system. And you can see that here. So when you see that, it's because there's dead bowel. somewhere. So here, you can see it here, there's this air around the wall of the colon. That's called pneumatosis intestinalis. That's when the bowel is infarcted, and basically the air goes into the venous system and then into the portal venous system. So that's a bad sign, and patients need to get urgent surgery. Here is another example of ischemic bowel. So you see how the bowel wall is thickened and it's like non-enhancing. So it's dying ischemia, and it's because of an internal hernia. So there's this mushroom-shaped appearance here, and it's herniating through this little defect here. So that's dead bowel from an internal hernia. Or it's dying. It might not be dead yet, but it's dying. Or at least hemorrhagic, because the bowel is thickened, it's hypertense, and not as enhancing. Here's a similar dead bowel appearance in children. That's called necrotizing enterocolitis. They get air in the wall of the bowel, like you can sort of see here, maybe these little, it looks kind of dirty looking here, in contrast to clean wall here. So that's called necrotizing enterocolitis. It happens in premature children, and the air attracts into the portal venous system. It's sort of hard to see, but there's this like lucency here, this linear lucency, that's necrotizing enterocolitis. Okay. Paralytic ileus. So you can have abnormal, like adynamic ileus. So the bowel's not moving very much, and so then all the air that the patient swallows stays put. So that's what we see here. This is in contrast to normal bowel gas pattern, right? There's diffused bowel gas, and it's balanced, and it's involving all segments of the bowel. And that happens in patients who are on narcotics for pain, patients who are post-op, who have not returned to bowel function yet, patients, really sick patients, they have poor bowel motility, so that's ileus. Volvulus, okay, so volvulus, so here we have a radiograph, and there's this abnormal twisting of bowel. It's a bean shape, so this is sigmoid volvulus. And then this, on the other hand, is a child. So the stomach is here, the esophagus is, stomach, this is a duodenum, and the gastroduodenal junction is here on the left side. But here, you see this twisting, and it stays put on the right side. So this is called malrotation. This is the cartoon version of it. It's from the normal mesenteric bowel didn't migrate to the appropriate place, so it's on the right side. And so the pedicle is very short and narrowed. Instead of the normal broad mesentery, it's very narrowed. So it can twist on the pedicle and cause volvulus. So this is called volvulus complicate from malrotation. All right, moving on to liver, 9:30. So here we have a patient who has very small liver, and it's nodular. There's also gallstones here, but you see large volume ascites. Patient also has, it's hard to see, but splenomegaly. There's hydrothorax. So there's fluid in the chest, pleural effusion there. So, and so in patients who have that, they can get TIPS. And the patient has, sometimes they can have upper abdominal varices, like a little bit of tingling. Sometimes it can be in the stomach or in the paraesophageal region and cause massive bleeding. Okay, so that was cirrhosis. Okay, so moving on. So cirrhosis, the best test for cirrhosis is called an MR elastography, which is what we see here. So there's an external coupler that sends waves, and it's an MRI that's done. And then it generates this like an elastogram. And so the red parts are cirrhosis. The green are like stage 1, and then the yellow are like stage 2, 3. This is a study of choice to assess fibrosis, cirrhosis. This is the external coupler that is attached to the patient when they, to send the vibrations into the, let's see, I want to show you the external coupler. So in the MRI scan, they have this, oh, I'm sorry, it's not coming out, but let's see. So this external coupler that gets attached to the front, and it sends waves. It sends wave, as you can see here, and that's the waves that we see here. And then you can assess how stiff something is in the liver, and then diagnose actually stage the fibrosis. Cirrhosis is end-stage fibrosis, but there's 4 stages: 1, 2, 3, 4. 2 and 3 are treatable. 4 is irreversible. That's called cirrhosis. You have like bridging fibrosis. So you want to detect it early and use either MRI or ultrasound elastography to assess what stage they're in. Okay, more stuff in the liver. So here we have liver, and this is a spleen, and you see the density of the liver is darker than the spleen. So that's hypodense. This part of the vessels, the hyperdense area. So this is alcohol. Oh, not alcohol, but it's just fatty liver, hepatic steatosis. It can be from alcohol. Most commonly now, actually, is from obesity and epidemic. The obesity epidemic. But you just have that deposition in the liver, and eventually that can lead to fibrosis. If it's non-alcoholic, from just like our obesity epidemic, then we call it non-alcoholic fatty liver disease. If it's from alcohol, then obviously it's from alcohol. But the problem is that it can lead to end-stage cirrhosis, and so patients are at increased risk for HCCs, and we need to be careful about that. So here it's a MRI. So this is called the in phase and a post phase. So MRI, we said is like having apps on the bones. This app is called in and post phase, and it looks at fat content. So here on the post phase, it becomes dark. So it goes bright and dark. And so this is diagnostic for fat. And using MRI, we can tell you exactly how much fat there is in the liver to monitor the patient's progress, right? Because you want to try diet therapy. And the whole idea is to prevent this patient from going into the fibrosis, cirrhosis pathway and NASH. So MRI can diagnose and quantify fat. In contrast, this is normal liver. So this is in phase, out post phase. This has no fatty liver, so this is normal. And so this is abnormal, fatty deposition of liver. So this one, let's talk a little bit more about cirrhosis, complications of cirrhosis. So the patient has end-stage cirrhosis, and you see these little paraesophageal varices. Patient came with massive bleeds, upper GI bleed, and just vomiting, hematemesis. They tried to clip him, couldn't do it endoscopically. You see these submucosal gastric varices. The patient also, so here you can see the small liver, the spleen is huge, right? So this is portal hypertension. There's all these collaterals, varices right here that's causing the patient's bleeding. So the patient went on to get a TIPS to decompress the system because there's portal hypertension. There's portal venous system is high pressure because the liver is so stiff. It's so hard that it's not able to relieve the normal pressure in the portal system. So you can iatrogenically relieve that doing this procedure called TIPS, where you make a communication between the right portal vein and the right hepatic vein. So the right portal and the right hepatic. So you bypass the liver. You're basically bypassing the liver using this to decompress the varices so that the patient doesn't die of exsanguination from hematemesis. So that's what TIPS is. So, all right, CBD stones. Okay, 940. Here we have an MRCP. MRCP looks at the biliary system. It's an MRI study. And you do an MRCP when you're trying to understand what's going on in the bile ducts. So this patient here this is a CBD. This is the duodenum. This is the right and left hepatic ducts. And this is severely dilated. And it's dilated because of this little guy here. This is a filling defect. It's a stone. It's a stone in the CBD. And sometimes it can migrate from the gallbladder. We don't see the gallbladder here because it was resected. So this just has a CBD stone. And so here's the pancreatic duct. So then the gastroenterologist can go in with ERCP endoscopically and then do a sphincterotomy, open up the ampulla, and then balloon. They could just do a balloon sweep to remove the CBD stone to relieve the obstruction. CBD cholecystitis. So you can get complications of gallstones when the cystic duct is obstructed from a stone or something else, like if there's an inflammation, it can also cause obstruction of the cystic duct. And here we see the gallbladder is markedly thickened. There's distension, and there's inflammation. So this is acute cholecystitis. The key is, you want to make sure there's not a CBD stone, because you might be able to take out the gallbladder, but if there's abnormal, bilirubin and you're worried about a CBD stone, you need to get an MRCP, because you can get CBD obstruction, because the cholecystectomy doesn't address the CBD, it only addresses the gallbladder. So we need an MRCP if there is elevated bilirubin and you're worried about obstruction. All right, so here is a gallstone that has migrated into the ileum. So this is called gallstone ileus. Basically, there's an abnormal fistula between the gall CPD and the duodenum, and then the stone goes into the bowel and then causes a distal obstruction. Here is the transition point. You see the stone, and then upstream is markedly dilated. So that's called gallstone ileus. It's not really ileus, it's an obstruction. Ileus suggests that there's no mechanical obstruction, but here we have a mechanical obstruction. So that's actually like a misnomer, but that's also an ileus. Okay, biliary system. So here we have ultrasound. This is the gallbladder. This is a cystic duct. And this is the cystic duct is dilated. Here's so then the duct, the stone, this is the MRCP. The stone can cause compression of the CBD, even though it's not in the CBD, like a CBD stone. A ginormous stone can cause compression of the adjacent CBD and cause biliary ductal dilatation, which we see here. And this is called Moritzi syndrome. So you treat that with cholecystectomy. Now we're moving on to the biliary system. Here we have an MRI. This is the liver. Here's an axial liver. And you see the liver is, there's these little like reticulations. The liver also, if you look at the surface, it's nodular. So it's a hard diagnosis, but this is a primary biliary cholangitis. You need biopsy to make this diagnosis, but you see, all we can really say is that there's diffuse liver disease. It's an abnormal looking liver. The liver should look like the spleen, right? It's homogeneous like the spleen, but here it's very heterogeneous and abnormal signal intensity. Here, another problem with the biliary system is called PSC, primary sclerosing cholangitis. Patients with Crohn's, ulcerative colitis can get this. The bile ducts are abnormal. There's sclerosis, so scarring. So you get this bead appearance, it's like alternating dilatation strictures, because the actual bile ducts are abnormal, and it causes cholangitis, inflammation of the bile ducts. So good thing they do transplants for this if it leads to end-stage liver failure. Okay, pancreas, 950. So pancreas, here is a CT abdomen pelvis, spleen. This is the liver. This is the pancreas. This is the duodenum. And you see there's all of this inflammation around the pancreas. The normal fat intercalated into the pancreas is obliterated. So this is interstitial edema. So this is pancreatitis. You can diagnose pancreatitis with lipase and amylase, but we get CT because we have to diagnose complications. And one of the complications is called necrotizing pancreatitis. And here's an example of necrotizing pancreatitis. So the pancreas is no longer enhancing, and you get this fluid collection in place of normal pancreas. And this is patients with necrotizing pancreatitis have an 8-fold increase of death. So the high morbidity. I remember when I was a resident or fellow, like every year after Coachella, somebody always came in with necrotizing pancreatitis from binge drinking. So it's very dangerous. And so we do CT to not diagnose pancreatitis, but complications of pancreatitis. Here is calcifications in the stones, in the ducts, as well as in the pancreas. And this is a sequelae of acute pancreatitis. So this is chronic pancreatitis. After a while, it starts to calcify. The pancreas get really small. There's stones that develop. So that's chronic pancreatitis. Pancreatic pseudocysts, so patients who've had pancreatitis can develop fluid collections in and around the pancreas. That's called a pseudocyst, because it's not a cyst, it's just fluid that's been walled off. It's not a cyst, it's an epithelial line collection, but this is a pseudocyst because it doesn't have epithelium line. It's just fluid that's been walled off. So they call it a pseudocyst. So that's what that is here. And here's a bigger one here in the tail, a pseudocyst. So you have to have a diagnosis of pancreatitis that precedes diagnosis of pseudocyst. If you don't, then you're going to think about pancreatic tumors, cystic pancreatic lesions, IPMNs, not pseudocysts. You need to have a diagnosis of pancreatitis that precedes the diagnosis of pseudocyst, so that you're not confusing it for like more sinister conditions. So ascites. We've seen a lot of examples of ascites already, but here's another one. Just that happens in patients who have portal hypertension. Usually the liver is abnormal, cirrhotic, and they get free fluid, large volume free fluid. They can also get hydrothorax, large right pleural effusion. Patients who have refractory hydrothorax that doesn't resolve with conventional therapies, or upper GI bleeds from paraesophageal varices can get tips to decompress the portal system. But be careful, because you don't put tips on everyone, because when patients get tips, they have an increased chance of tipping over to liver failure, because you're bypassing the liver, so the liver is no longer getting fed by the portal venous system, so they actually get worse. But it's a balance of two evils. Like, should they die of upper GI bleeds, or should they die of end-stage liver disease? So it's you got to balance the risks and benefits. We've talked about adhesions already, but here are more examples of adhesions that happen after surgery. So here you can imagine like a waist that can cause like an internal hernia. Here's a really beautiful adhesion that causes a kink in it, but that's the leading cause of small bowel obstruction in adults. Trauma. Okay, so trauma, trauma, high velocity MVCs, motor vehicle accidents. Here we have a contrast enhancing CT, so there's blood around the liver. There's free air. This thing is up here is free air, and it looks like there might be contrast extravasation here, maybe like active extravasation. And here we have air in the Morrison's pouch. That's abnormal, and this is the duodenum, so that's retroperitoneum. So it's I'm sorry, I think I take that back. If it's Morrison's pouch, is not retroperitoneum, it's intraperitoneal. But anyway, so we have injury, bowel injury causing free air, and patients need to go into surgery right away to fix the bowel injury. Digestive system, we're talking about foreign body. This patient intentionally or unintentionally swallowed a nail. Sometimes we can get fish bones that sort of can cause obstruction and perforation as well. So trauma. So here is a patient who pelvis CT. This is the internal and external inguinal ring, external ring, and there's stranding and inguinal hernia that has gone into the internal ring. The internal inferior epigastric is here, so it's lateral to the inferior epigastric, so that's an indirect hernia. If it's medial to the inferior epigastric, that's a direct hernia, directly through the Hasselbalch triangle. Here the sagittal. This is a big hernia through the inguinal canal. This one has small bowel, mesentery. Sometimes they have colon, they have bladder. A lot of things can herniate. So here there's a femoral hernia. So it goes to the femoral ring, not the internal ring. And it's a femoral hernia because it's in the femoral triangle. It's right next to the femoral artery and vein. Here, the femoral artery and vein is here, so it's away. So this is inguinal hernia versus femoral hernia, which is, and sometimes it can compress the femoral vein. Femoral hernias are dangerous because usually the neck is very small, so it can get strangulated. So typically femoral hernias are corrected urgently because of risk of strangulation, because the neck is very small. And here is in a small bowel follow through. So the contrast is in the small bowel now, and you can see that this little hernia comes down. I'm not sure if this is, maybe it's femoral. Okay, so you guys are texting me. Is it time to go? I haven't been paying attention to your text, but see. No, no, sorry, I have to go to class, but thank you so much. Okay, so we can stop here. Let me see. Just stop the video. So this is a hernia. So this is a radiograph, sagittal radiograph, and we see that this is the abdominal wall. There is small bowel anteriorly, and here is a CT version of it. So there's small bowel that's outside the anterior abdominal wall, and there's fat and bowel in it. So this is an anterior midline ventral hernia. And it could be from different causes, trauma, prior surgery, yeah. So here, open wound abdomen. So this is a patient who had a high velocity injury. So we have free high density fluid that's hemoperitoneum, and there's stranding here posteriorly from a hematoma, and then there's fractures of the pelvis there, and then there's hematomas here with high density stuff here. That's active extravasation. So this patient has multiple injuries. So there's laceration of the kidney, there's a laceration of the spleen, and there's free hemoperitoneum and multiple pelvic and sacral fractures. So it's a high velocity injury with multiple organ and bone fractures. So here, this is a patient with upright radiograph, and under the diaphragm, there's this lucency here. This is called free air, where there's probably viscous perforation causing air to go under the diaphragm. So that's free air, and it can happen when you see that. You have to have a high level of suspicion and take the patient to the OR urgently. And here's a large volume free air with lucency under the diaphragm. Boerhaave syndrome is a condition when you have a perforation of the distal esophagus from forceful, increased pressure in a unrelaxed esophagus. So you get, here we have contrast extravasation outside the normal esophagus, and then there's this lucency here tracking, which is from pneumomediastinum with air tracking into the mediastinum. So that's Boerhaave syndrome. Here's an esophagram that shows you the perforation. So this esophagram shows that the esophagus is here, but there's this extra luminal collection here consistent with perforation that has to be surgically corrected. So here's a CT of Boerhaave syndrome. The other one was cervical perforation, but here there's free air here, and then there's free air throughout the abdomen. And when it scrolls up, we can see that there's air in the mediastinum. So this is air secondary to perforation. Umbilical hernia, here is the patient CT abdomen pelvis, and there's a defect in the ventral wall, and there's fat that herniates out. There's fat that herniates out here laterally, and that's a hernia. And sometimes the fat can strangulate and cause pain. Typically, it's asymptomatic, and you don't have to do anything about it because small bowel is not in it, so there's not a risk of strangulation. Here, this is an example of congenital malformation of the pancreas. So the pancreas normally abuts the duodenum, but in certain congenital abnormalities, the pancreas can go entirely around the duodenum. This increases the risk of pancreatitis, and that's what we see here. So the pancreas goes completely around the duodenum, which has contrast within it, and that's annular pancreas, which can increase the risk of pancreatitis. This is a HIDA scan. So this is a normal appearance of a HIDA scan. A HIDA scan is a molecular imaging study that follows bilirubin. So it gets excreted into the bile ducts and then goes into the small bowel, like we see here. There's bowel. And then there's the bright spot is the gallbladder, where there's collection. This patient is a neonate. There's uptake in the liver, but there's no excretion in the bile in the gallbladder or in the GI tract. So this is diagnostic for biliary atresia, which means the absence of bile ducts. And the patient has to, there's no CBD, so Kasai procedure is performed where they bring a loop of small bowel and connect it to the whatever duct is remaining, so that there's a way to drain the bile ducts. This can lead to end-stage liver failure if not treated. Here, congenital disorders called esophageal atresia. This patient here had an NG tube placed, and the NG tube coiled on itself. It's a young child. You can see that the physis is not formed. And this is because there's an atretic segment with discontinuity of the esophagus. Here we have an umbilical catheter. Here is an upper GI. It's in a young child, and what we are looking at is normal. This is the normal upper GI in a child. The gastrojejunal junction should be in the left upper quadrant, but here we see, which is what we see here, right? The bowel goes to the left side. In contrast, in this abnormal study, the patient has contrast and it stays to the right of the abdomen. So this is called malrotation because there is incomplete rotation of the bowel to the left upper quadrant. Congenital disorders. So here we have a complication of malrotation. It's called a midgut volvulus. So the patient's, the malrotated bowel is on the right side. The pedicle is very narrow, so it can twist on itself and cause malrotation and volvulus. So there's no contrast that passes into the jejunum. And this has to be urgently surgically corrected, otherwise they can infarct their bowel. This is a Meckel's diverticulum, which is a diverticulum of the ileum. And some subsets of diverticulum, it's a remnant, congenital remnant from a, communication. It's called Villatine. So the Meckel's diverticulum, it's a congenital diverticulum from a remnant of the omphallomesenteric duct, also called the Vitelline duct or the yolk stalk. And a portion of it, like 50%, can have gastric mucosa in it that causes bleeding, and that can be diagnosed with a Meckel scan. And you can see there's this increased focal uptake that increases over time. So that's consistent with the Meckel's diverticulum. This is an ultrasound image of a patient with pyloric stenosis. So this is the liver, this is the stomach, this is the pylorus. And you can see the pylorus, it's thickened and it's elongated and it's not relaxing. And that's what happens in patients with pyloric stenosis. You can have this little palpable ball, they call it an olive appearance or sensation, and it's it's not relaxing. So children can have intractable vomiting and intolerance of PO. This is a CT with an markedly enlarged stomach, and we see that the antrum of the stomach is thickened and abnormal. This is gastric outlet obstruction, causing gastric outlet obstruction. This abnormality can be seen with. This is gastric cancer with gastric outlet obstruction. The mass is here in the distal antrum. This is a gastric emptying study. Patients eat a burger that is mixed with technetium colloid, and then we look at the gastric emptying. Here, it doesn't empty as expected after 90 minutes. So this is consistent with gastric paresis, which happens in diabetic patients, which is different from gastric outlet obstruction, where there's an obstructing mass or lesion. But they can have similar presentation of nausea and vomiting, although the underlying pathophysiology is different. This is a patient with a tracheoesophageal fistula. So it's an esophagram, and there's contrast here. This is the spine. This is the heart of the patient. Patient's facing this way, rotated to the right. And when the patient drinks fluid, it goes into the airways. The bronchogram, bronchial anatomy is highlighted. So there's an abnormal communication between the bronchial and the esophagus. Excuse me. There's an abnormal communication between the esophagus and the bronchial anatomy. So to close our lecture, this is an esophagram, and we see there's abnormal contractions consistent with dysmotility. Left lower quadrant pain, this is a patient with diverticulosis, and this is complicated by diverticulitis, and there's abnormal stranding. There's also ovarian cysts. This is a patient with abdominal pain. There's abnormal ileal thickening, enhancement, and engorgement consistent with enteritis. In this case, this is a long segment abnormality. This is, can be seen with Crohn's. This is a liver protocol study. We do a non-contrast, contrast, enhance, and then the washout phase. And you see the mass is enhancing and washes out. And that is a HCC because the patient has background cirrhosis. This study is called transarterial chemoembolization TACE. This is before the beads are released into the parasitic vessel, feeding the liver HCC. And then this is the post-TACE ablation after the artery to the mass has been blocked off by beads. And that's the TACE run. The study, the diagnosis in this case, there's dilated bowel, small bowel, and then there's decompressed distal small bowel. So this is a small bowel obstruction, and this is the transition point where the dilated bowel becomes markedly narrowed, and the most common cause is adhesions. This study is a CT colonography. There's air that's insufflated into the colon, and the study is used to screen for colon cancer. It's recommended by USPFTF as an alternative form to colonoscopy and sigmoidoscopy with fecal occult blood. This is a MRI, and this is in phase, out of phase. So MRI has the capacity to quantify fat in the liver, and it can be used to monitor treatment for patients with hepatic steatosis. So this is what we did. Thank you so much for your time.